Hello, everyone, and thank you so much for joining us. This is Bethany O'Connor from Health Policy Plus, and I am delighted to welcome you to today's webinar entitled Health Reform in Nigeria, A Journey Towards Universal Health Coverage. We have a great broadcast for you today, and we'll begin with just a few announcements. The session is being recorded, and as always, we will post the recording on the HP Plus webinars page. We would love to hear from you, and we welcome your questions at any time. Please submit your questions via the chat box on the right-hand side of your screen, and I will read them aloud when we pause for questions. These web conferencing platforms are getting an unusual amount of traffic, and we ask that you just bear with us in case there are any glitches with the technology. Finally, we ask that if you're not speaking, that you please mute yourself to keep the line nice and quiet while others are talking. And that concludes the little announcements portion. So now let's meet our presenters. Next slide, please. Our presenters today are Sunita Sharma, the HP Plus Project Director who holds a PhD in MPH. Francis, we need the next slide. Oh, perfect. Okay, great. So Sunita Sharma, our Project Director who holds a PhD in MPH. Francis Alika, our Country Director for HP Plus Nigeria, a medical doctor who also holds an MPH. Adeni Ogini, Executive Secretary for the Osun State Health Insurance Scheme, a medical doctor who also holds a PhD in ecology and environmental science. And I'm your host, Bethany O'Connor, delighted to be with you today. And now that we have met our panelists, let's look at our agenda. Next slide, please. Dr. Sharma will give our introduction and highlight some of our key achievements. Then we'll do a deeper dive with Dr. Alika on key program highlights. Then Dr. Ogini will share perspectives on working with HP Plus in Nigeria, which is such a special treat, and we're really excited to have him with us. And then Dr. Sharma and Dr. Alika will wrap up with some lessons learned, and then we will move on to question and answer. So without further ado, it is my pleasure to hand it over to my colleague, our project director, Sunita Sharma. Sunita?
Thank you very much, Bethany. Countries around the world are embarking on major health sector reforms to expand equitable access to quality healthcare services and improve health outcomes. Health sector reform is inherently a political process that alters roles and responsibilities of key actors and distribution of resources across health sector and beyond. These are daunting efforts for many health systems that are already under-resourced and overstretched. Implementing health reform is complex, multi-level, and interlinked. It requires significant financial resources and planning. Policies, programs, administrative structures, and guidelines need to be generated and implemented. Stakeholders at all levels of health systems need stronger capacity to achieve and sustain higher levels of performance, and viable accountability and communications mechanisms need to be sorted, all of which need to be finally tuned to work together to move reform forward. Given these challenges, we may ask, how can large, fragmented, and complex health systems align health system functions such as governance, financing, regulation, and organization of service delivery to achieve universal health coverage? Can countries follow through on their commitments to their citizens for better health access with greater financial protection, and do so with more reliance on local systems and domestic resources? I'm convinced they can. I say that because USAID Nigeria gave the Health Policy Plus project the opportunity to help advance Nigeria's ambitious health sector reform efforts. We often say that policy reform and implementation take time, but with a favorable enabling environment, committed public stewards at all levels, engaged citizens, and targeted assistance, we have seen that policy can translate very quickly to action and to better access to healthcare services. to Nigeria's most vulnerable. We know that magic can happen. Nigeria's gateways for these reforms, the Federal Ministry of Health, the National Health Insurance Scheme, the National Primary Healthcare Development Agencies made great strides in operationalizing key health reform efforts. These are: one, the Basic Healthcare Provision Fund, which was designed to substantially increase resources for health, extend primary healthcare services across the country, and provide financial protections for some of Nigeria's most vulnerable groups. The Basic Healthcare Provision Fund aligns the interests of the federal and state government by requiring states to match federal contributions, redefines the basic package by re-establishing priorities, overcomes huge bureaucratic obstacles present in the traditional budgetary system by making automated disbursements to states that have crossed a threshold of minimum requirements. Two, the primary healthcare under one roof policy, which was created to reduce fragmentation of primary healthcare management systems and promote compliance to quality of care standards. Three, align health insurance administration and schemes to the states in order to expand access to high quality healthcare services and provide additional financial protections. Four, to unlock and mobilize additional domestic resources to fund these reforms. In just 18 months, the national, state, and local governments in 3 pilot states and the Federal Capital Territory were able to enact long stagnant policy requirements for states to participate in and tap into federal funding for reforms. With new levels of coordinated stewardship, the 3 gateways set up new governance, administrative, and accountability structures for implementation, and they joined together to prepare PSCs and ward development committees to carry out their new roles under the reforms. And most importantly, they pushed through operational challenges until they succeeded. They succeeded when policy met service delivery, when commitments came true, and thousands of Nigerians started receiving essential services for free at their local PSCs that had not been possible before. And the administrative wheels of whole system turned such the PSCs are being directly reimbursed for the services rendered. As the number of participating states grows, the government of Nigeria has demonstrated its capacity to follow through on the commitments envisioned in the National Health Act 2014. I share a great deal of optimism for the future of health reform in the country and for Nigeria's journey to self-reliance. I will now ask our HP Plus Nigeria Country Director, Francis Heka, to share the story and more details of the achievements and challenges along the way.
Thank you very much, Sunita. Thank you, everyone, for tuning in. So I'm actually delighted at this point to share with you some of our successes and the work that we did in supporting Nigeria towards its universal health coverage goals. So the Health Policy Plus project in Nigeria, funded by USAID, actually supported the Nigerian system to implement policies that had already been enacted but had not gained a lot of traction. So what we did at HP Plus was that we acted as a catalyst to speed up the implementation of these excellent policies that were already in place. Sunita had mentioned some of these policies, including the Basic Healthcare Provision Fund, which is actually seen as something that is a game changer for the Nigerian health system, with a potential to release on average about 55 billion naira every year to increase availability of health funding at the subnational level, including supporting other brilliant policies like primary healthcare under one roof, which improves primary healthcare governance, reduces fragmentation, and improves quality of care at the primary healthcare level, and supporting interventions and good policies like state health insurance schemes, which ensures financial protection for the poor and vulnerable at the community and state levels. So these were already brilliant policies that were in place by the Nigerian government, but hadn't gained a lot of traction. So what HP Plus did was that we partnered with the government across all levels using a very unique whole system strengthening approach. We provided support, capacity strengthening, hand-holding, and facilitation of the implementation of these policies across all levels, from the federal level, supporting the federal level agencies, at the state level, supporting the state institutions and agencies, down to the local government level, who have direct supervisory role over these primary healthcare facilities, and down to the facility level, where these services, people can actually access these services, and even down to the community level. This is actually quite a unique approach that not many people have actually taken. And this was what led to the results that we saw. So supporting these interventions actually created the impetus for the policy reforms and prioritization of the health sector by the government. And we'll be going into some more details soon. As a result of this, we repositioned the supported states, which were Abia, Osun, Ebonyi states, and the FCT, in their UHC goals of moving gradually towards improved access, financial protection, and efficiency in health systems reforms. In going into a little bit of details with regards to the areas of support that we provided to the states, we worked across four major pillars. The first pillar is regards to domestic resource mobilization. So our focus of work here is to ensure that we actually mobilize domestic resources. So we increase the prioritization of health at the different levels of government, at the federal, state, and local governments, to actually spend more towards these health reforms. How did we do this? We supported the states to generate evidence, strengthen institutional structures that would drive these reforms, develop resource mobilization plans, and actually strengthen the capacity of actors to be able to get this, translate this into real results. As a result of this, about 58 million additional funds was mobilized for the health sector through different mechanisms, increased allocation and releases to the state health insurance schemes, spending of money on PHC revitalizations, as well as fund releases through the Basic Healthcare Provision Fund. As a result of this, we actually strengthen the capacity of these actors to engage government and make sure that health is prioritized and domestic resources are released for health services implementation. The second key pillar we worked on was what we call the supply side of universal health coverage, which is strengthening primary health care to ensure that there is access to quality health care at the primary health care level. We strengthened the necessary institutions down to the level of the local government health authorities. And as a result of this, there were great improvements in PHC governance, reduced fragmentation, as well as strengthened capacity to provide quality healthcare services. The third pillar that we worked on is actually the pillar of health insurance, which we call the demand side. So what this did was that it helped to provide financial protection, especially for the poor and vulnerable, to be able to access basic healthcare without financial hardship. And we also supported them, and we'll get into some more details with regards to the results that we were able to achieve in this space. The final area that we supported is with regards to the Basic Healthcare Provision Fund. Sunita had already given some overview of the capacity of what this Basic Healthcare Provision Fund could achieve for the Nigerian health sector. Notably, many actors, if you ask them in Nigeria, will tell you that HP Plus is synonymous with Basic Healthcare Provision Fund, because based on our work with partners and with stakeholders, we stimulated and catalyzed the implementation of this excellent reform that had been passed by laws and there were policy documents, but was not being implemented fast enough. So we provided the catalyst by developing an implementation package for its implementation, and guiding all the necessary structures, building capacity to make sure that this is implemented. All this work, of course, we did while using a gender and equity approach, capacity building, sustainability, as well as monitoring, evaluation, and learning towards self-reliance. And our definition of self-reliance is when Nigerian domestic resources are effectively and efficiently mobilized and utilized in a sustainable manner to provide quality services to all Nigerians in order to improve Nigerian health outcomes. I would like to highlight briefly the key achievements or accomplishments that we were able to achieve within the small period of 18 months. So in the supported states in Abia, Osun, and Ebonyi states, we supported the government to mobilize additional 58 million US dollars through the state health insurance schemes, which for the first time got budgetary allocations and releases in form of equity funds, take-off grants to cover for the poor and vulnerable populations, increased allocation and releases to the health sector through primary healthcare revitalizations, as well as increased releases through the Basic Healthcare Provision Fund. In addition to that, we also performed other work to support family planning in Sokoto, Bauchi, and Ebonyi states, which released additional $1.2 million. With regards to key policies, we supported the states to ensure the formation of key policy documents, including laws that actually provide legal backing, as well as makes provision for the implementation of these good policies that have already been established in the states, including the passage of 2 state health insurance bills in Osun and Ebonyi state, as well as the passage of the primary healthcare bill in FCT, which ensures reduced fragmentation and budgetary provisions for primary healthcare in the states. In addition to that, we also supported the state health insurance schemes from the period of design, legal framework, design of benefit packages, setting up their institutional structures, building the capacity. Many of these health insurance schemes had staff posted to them that had no idea what health insurance was all about. So there was a lot of intensive capacity strengthening, supporting the structures, and we provided the support to these states up to the level where they actually launched their schemes, started enrolling people into the schemes, and even started providing services in some of the states. In Osun State, within a space of 4 months, they were able to enroll additional 207,000 people into the state health insurance scheme within a very short time. Some of the things that made this possible was successful domestic resource mobilization and advocacy to the government to release money to enroll the poor and vulnerable population, as well as successful advocacy to enroll the formal sector government workers into the scheme. In FCT, the FCT health insurance was already in existence, but as a result of the work that HP Plus did, we supported them to realign their health insurance scheme, because before now, it was only covering the formal sector. But in the spirit of UHC, we supported them to realign it to cover even the informal sector, including the poor and vulnerable. And we supported domestic resource mobilization advocacy to get funds released for them to be able to do that. In addition to that, we also achieved a lot of results in primary healthcare, where we worked, the states that we supported actually had a 43% improvement in the primary healthcare under one roof scorecard, from scorecard 4 to scorecard 5 in a period of just 1 year. The national average was 23%. Notably, one of the states we supported, which is Osun State, actually made an improvement from the 29th position under primary healthcare governance and structures in Nigeria to the first position as a result of support of HP+. We didn't quite stop there. Many of the states actually had provisions in the primary healthcare under one roof policy for local government health authorities who had direct supervisory role over the primary healthcare centers, and they were quite closer to these primary healthcare centers. But many of these were not existent in many of the states. So HP Plus supported high-level advocacy using evidence to get the government to actually set up these local government health authorities in many of the states that we supported, and built their capacities to be able to provide supportive support to the primary healthcare centers to provide quality healthcare. Finally, one of the things we did in this area is that we also supported the setup of institutional structures through multi-sectoral technical working groups to work together to drive these reforms. as well as health financing units that will continue to generate this evidence and use it to advocate to policymakers. And we're hoping that these are some of the things that would ensure the sustainability of these interventions. Finally, by way of achievements, one of the key greatest things that has happened to the Nigerian health system is the Basic Healthcare Provision Fund passed in the National Health Act of 2014. So this provides that about 1% of the consolidated revenue fund of the country should go towards ensuring adequate healthcare services at primary healthcare level and providing financial protection, especially for the poor and vulnerable. This policy was actually in the books. A law had been passed, but a lot of progress hadn't been made. HP Plus supported the government agencies from the national level as well as the state level and brought together stakeholders to develop an implementation package that actually specifies the day-to-day processes of implementing the scheme. We didn't just stop there. We actually provided support to train different levels of trainers, marathon of trainings at the national level, at the state level, and even down to the local government level, training of primary healthcare officers, healthcare providers, as well as training of ward development committees who will provide oversight on the primary healthcare facilities to make sure that these services are being provided. In addition to that, we also ensured that there were social accountability mechanisms in place through the ward development committees, who are like community development committees who volunteer their time to make sure that people have access and that their primary healthcare systems, facilities are working adequately. And we conducted over a lot of town hall meetings where over 100,000 people were reached. As a result of this led to increased enrollment in 2 states as well as the FCT of close to 300,000 people had enrolled within this short period of time. And out of this, about 120,000 people had received free services through the Basic Healthcare Provision Fund as at the time that the activities ended. In addition to this, we also supported the states to qualify to access funds through the Basic Healthcare Provision Fund. Notably, the 3 states and the FCT supported by HP Plus were the only states in the whole country out of 36 states that actually got the approval to release funds down to the facility level. And for the first time, many of these primary healthcare facilities that didn't have any basic funds to get basic things like water, equipment, electricity, got funds released to them for the first time. And they were also supported to develop business plans, quality improvement plans, and trained on financial management skills that help them to be able to utilize these funds efficiently to equip their facilities, buy basic water, buy basic equipment, and begin to provide services to their people. In addition to this, we also strengthen the capacity of the local government health authorities to provide supportive supervision to these PHC facilities to make sure they are able to provide these services adequately. As a result of this, there was a lot of ripple effect in many of the communities. As community members, through the guidance of the ward development committees, mobilized themselves and started doing things on their own for their own facilities. In many of the communities, community members helped to restore electricity to the facilities. They bought hospital beds where they didn't have enough hospital beds. They provided water supply, and they did a lot of things out of the excitement that now service delivery can begin once again in our moribund primary healthcare facilities. Now, I would like to reflect a bit on the work that we did using the lens of self-reliance, because one of the things that we did was from the start of the implementation of this program, we wanted to ensure that we imbibed self-reliance. And I would like to discuss this in 3 key areas. First is financing self-reliance. So one of the things that we did was that we helped to make sure that the health financing reforms were instituted and implemented. Many of these health financing reforms actually had built-in their legal documents provision of finances. For instance, the Basic Healthcare Provision Fund had finances already built in it, and they just needed to be stimulated or needed to be released through the implementation of these policy reforms. For the state's health insurance schemes, many of them actually didn't have. For instance, in Abia State, we supported the state to make sure that the financial provision that was made in the law that established the state health insurance scheme was included in the state budget and appropriated for the first time. This will actually ensure financial sustainability of these interventions. We also supported the states to develop financial sustainability plans, making projections to say, if these schemes were to be financially sustainable, what do you have to do over the years so that they don't run into trouble or deficits over the years, and instituted structures to make sure that this was being implemented. And of course, we made sure that the government funds were secured and made sure that there was capacity to continue to stimulate the release of these government funds. The second pillar is through operationalizing policy commitments. So we supported the states to make sure that the government commitments that were made were unlocked. For instance, in Osun State, they had appropriated for 1% of the consolidated revenue fund as equity fund for the poor and vulnerable population. And we supported the states through high-level advocacy, good understanding and application of political economy to ensure that 447 million naira was actually released, which was used to enroll the poor and vulnerable into the health insurance scheme. The Dr. Guinea, when he speaks later, will actually be providing more details with regards to what they did with this money and the impact that it's already having in the communities. We also made sure that legal and operational guidelines were developed and they were implemented and not just left for the shelves, and also ensured that evidence generated actually led into policy formulation and that these policies were actually implemented. The third arm actually speaks to strengthening capacity and local stewardship and sustainability. So one of the things that we did to make sure that these stakeholders are able to continue implementing these wonderful interventions after we're not there anymore is to strengthen capacity at all levels. Like I mentioned earlier, we used a unique approach of building capacity from the federal level across all the key agencies and structures and institutions. At the state level, all the key agencies and structures and institutions, down to the local government health authority, down to the facility level, and even down to the community level, to make sure that the people who are going to do this job have the necessary capacity to continue to do it moving forward. We also strengthen multi-sectoral collaborations across the key sectors. So before now, people from ministries of budgets and finance didn't really talk to people from the ministries of health. And these are the people that can draw resources to the health sector. So we strengthen these relationships through multi-sectoral technical working groups where they speak to each other and actually talk about the need to spend more on health, which made the health sector to be seen as more transparent and then therefore attracted more funding to the health sector. Of course, we also strengthened social accountability and citizens involvement mechanisms through the ward development committees, the communities. I had given the report about what some of these communities are actually doing and mechanisms for them to provide feedback on the implementation of these very important policies. So I would like to end with this slide that actually talks about some of the testaments that came from the people who benefited. So the first one on the left is actually talking about our capacity strengthening of institutions. So this is from one of the board members who actually testified to the fact that as a result of the capacity strengthening of the board of the primary healthcare agency, they are able and they understand better how to steer the affairs of primary healthcare in their community and in their state to ensure better quality healthcare. On the top left is actually an officer in charge, a healthcare worker in a rural primary healthcare center in Osun State, who actually talks about the impact that this capacity strengthening, as well as the improved funding of primary healthcare has had on the staff. We know that one of the biggest issues with Nigerian health system is human resources. And this impact is already being felt at that level to stimulate and actually inspire the health workers to perform better. On the left side, at the bottom side, you can see a testament from one of the beneficiaries. And Dr. Ogini will be giving us more stories about this later, about how this woman's life was changed as a result of these interventions that are going on. And finally, I would like to end with a statement from one officer in charge who is already talking about the impact of these interventions on healthcare utilization in a rural primary healthcare level. At this point, I would like to invite Dr. Ogini, who would actually give us a first-hand account of the impact that this support and the successes that HP Plus work has done in Nigeria, the impact that is actually having at the state and community level. Dr. Ogini.
To be here once again. The work of HP Plus in Osun State, I would say, laid the foundation for the true implementation of the reform towards universal health coverage in the state. By the time we came on board, we didn't have much knowledge about healthcare financing. We never had a state health insurance agency, and it was a new paradigm. It was a new, reform altogether in the health sector. But with the help of HP Plus, we were able to go through all the motions of setting up a vibrant and virile agency to run the state social health insurance scheme. All of the stages that we went through, from the development of the policies, the advocacy for the law to be formulated and to be passed, the development of benefit package, operational guidelines, every of these steps were, supported technically by HP Plus. So in all of this, as we got new staff into the agency, there was training, there was capacity building, and institutional, capacity was developed to operate a state social health insurance scheme. And the effect of this was that within a very short period of time, we were able to enroll into the scheme 41,414 in the formal sector who are actually principal enrollees. As I speak now, for those 41,414, we already have up until this moment 60,000 additional beneficiaries of the 41,414 formal sector participants. Our informal sector enrollee has also increased to 350 as at this morning, and the 127,000 vulnerable individuals that are already in the scheme we got through intersectoral collaboration with Bureau of Social Services, because you'd wonder, how could we have done within a very short time? How could we have enrolled 127,000 vulnerable populations, people in the population into the scheme? This we actually achieved through the capacity that we had gained in intersectoral collaboration. Working together with the Bureau of Social Services, we were able to get the social register for the state. And all we did was just to validate the social register for the state and empanel and enroll the vulnerable onto the scheme and empanel them to primary health centers. Now we know that, Frances has said quite a lot about the work that was done with the State Primary Healthcare Board, because it is actually a result of the strengthening of the primary healthcare system in the state that created the facilities, that is the supply side for universal health coverage. The facilities were renovated, the governance structure of primary healthcare was improved through the assistance of the HP Plus in Osun State. So as at the time we were completing the issue of validation of the social register, we already had primary health centers that were ready to deliver service to the people that were enrolled under the scheme. So we had a seamless transition. People were brought in from the demand side. The supply side was ready to provide services. And the same thing that another thing we enjoyed from working with HP Plus is that it was HP Plus that actually helped us in, the determination of service readiness for those facilities to be able to onboard into the basic healthcare provision fund, because there were certain criteria that had to be fulfilled before the BHCPF fund would release to the state. And so the service readiness assessment in the primary health centers that will be giving care at the primary level to our enrollees, particularly the vulnerable population, was actually supported with the help of HP Plus. So we quickly completed our service readiness, availability readiness, and were able to access the fund. One of the key areas also, which I would say working with HP Plus has done, is to affect the psyche of the community. They got involved in community engagement, and before long, over 30,000 residents had been sensitized on the BHCPF. And you know, the BHCPF was actually supposed to lay the foundation for entry into the state social health insurance. And this was perfectly done through the efforts and the support of HP Plus in community engagement. And what we had was also improved coalition of civil society organizations for social accountability. In fact, the civil society's coalition organizations are involved as third-party administrators in enrollment, in marketing, in publicity of the health insurance scheme in the state. So they work both for the Basic Care Provision Fund and for the state health insurance scheme. Perhaps the biggest area of achievement, which I would say working with HP Plus has given to me, is domestic resource mobilization capacity. We actually advocated, together with the support of HP Plus, for the release of 150 million naira. The equivalent of 150 million naira is about 397,000 US dollars. That's approximately 400,000 US dollars was released to us as takeoff grant for us to establish the health insurance agency. Aside from that, we also got the release of about 148 million naira. The 477 million naira, that is as equity grants. This 477 million is an equivalent of 1.265 million US dollars in a state where nothing would have been given in this area of state health insurance because of the work of the health, the support we got from HP Plus in evidence generation, in arts of advocacy, high-level advocacy, and intersectoral collaboration with the ministries of finance, of budget and planning. We were able to come up, to get this 477 million naira, that is equivalent of 1.265 million US dollars released for us to be able to implement our activities. And we were able to secure a budgetary allocation both for 2019 and for the current year 2020, some of which has been released for us to be able to continue with our work. Thank you. Next slide, please. Next slide. Okay. Next slide. Now, HP Plus came to us at a critical point to lay a very solid foundation for the agency to work. And I must tell you that the work of the HP Plus here has not only been of benefit to Osun State alone, it has touched every other state of Nigeria that are at different stages of their development of the state health insurance agencies. And I will let you know how it did that. Right now, as I speak, I am the chairman of the Forum of Chief Executive Officers of state health insurance agencies in Nigeria. And because across the 36 states and the Federal Capital Territory, these states are at different stages of their development. Those that did not have the privilege of being assisted by partners like HP Plus, we always having recourse to us to ask, please, how did you do this? How did you go about developing your benefit package? How did you go about developing your operational guidelines? How did you determine your premium? All of this we were assisted to do through the technical support we got from HP Plus. And so all the documents we have generated, the skills that we have acquired and our knowledge is also extending to other states in the Federation through the work that HP Plus did in the state. The HP Plus actually held our hands while we developed all our process. And you can see the results. The lady that is in the top left corner of the screen is Ramata. Ramata was a patient that ran into a burning building just because she remembered that 1,000 naira, an equivalent of $2.65. Because of $2.65, this lady ran into a burning house to salvage that money, and she lost both hands. If she didn't have a scheme like the Osun Health Insurance Scheme taking care of the vulnerable, she would be a dead person by now. But this patient that you are seeing had bilateral below elbow amputation done, and this was done at no cost to herself or to the family. Everything was borne by the State Social Health Insurance Agency. And aside from that, through sectoral collaboration, we are already linking her with the Ministry of Women Affairs so that she can be rehabilitated and her life can be meaningful. These are some of the things that we have seen. If you see underneath in the bottom picture, you see Her Excellency, the wife of the governor of the state of Osun, presenting a card to one of the abandoned children in the government orphanage. We enrolled every child in the government orphanage and all private orphanages in the state. Aside from that, we also enrolled all the students that are in the school for the special needs, those that have physical challenges, mental challenges. In those schools for special needs, all of them are enrolled and they are receiving quality care under our scheme. What I would say, conclusively, is that we have learned self-reliance through the work of HP Plus. And one of the evidence I will give as one of our achievements in self-reliance is that aside from the benefit, the plans and the processes and the manuals that we developed together with HP Plus, in our desire to up our game, we also engage a consultant that would help us, a quality consultant that will help us review our manuals and modify them so that they can meet ISO certification. So at the moment, we are working towards ISO certification of our state insurance in all our processes, whether they be claims management, whether they be quality control, whether they be all enrollment processes. We want all our processes to be certificated internationally. And aside from that, we also, to counter the issue of incessant out of stock and ill treatment of our health insurance enrollees in the various facilities where our enrollees are receiving treatment, particularly the government secondary health facilities. What we did was to get a memo to the Mr. Governor, which he approved, that we should establish an Osun Health Insurance Scheme Drug Distribution Center. Now we have established a scheme. All the first set of the seed stock of medicine has been put into the pharmacy. From here, we are going to be supplying to our government accredited facilities, and they are going to be paying back from whatever we're giving them as capitation and fee for service. This way, the issue of there is no drug in our hospital for our enrollees will be a thing of the past. And we would have set up the scheme on a sustainable basis. As we recover the money, we buy more drugs, all our facilities are served. And we're looking forward to a time when we would also be serving other stakeholders, other facilities that might want to come and purchase our drugs, because at that time we know that our drugs will be coming at a price that's a little lower than that in the market, and service providers will love to purchase our drugs. Now, these are the things, and of course, other states are asking, how do we do this? How did we do it? And we are, passing things across to them. So, ladies and gentlemen, at this point, I would like to call on Sunita, my colleague Sunita, to continue the presentation. Thank you.
Thank you very much, Dr. Ogeni. We highly admire your excellent stewardship and support. So I would like to share some lessons learned. It is important to align resource mobilization and implementation efforts with existing frameworks, policies, and country priorities. This enables the achievement of results efficiently and effectively. Other lesson learned, which is we heard from Francis and Dr. Ogeni, decision makers at all levels need evidence to guide choices on domestic resource mobilization, implementation, and coordination. Generating evidence and promoting use of evidence are crucial for ensuring that government spends well and spends better on health and disease programs. Decision makers need to understand both technical and political implications of policy and financing choices. Political economy analysis is an integral part of health sector reform processes. Implementers need to proactively engage government stakeholders and continuously review the political economy landscape to inform who and how to engage towards successfully implementing a policy action. And we also need multi-sectoral action. A number of central budget agencies and the parliament play a huge role in allocation and release of funds, creating platforms that bring these diverse institutions and actors together promotes mutual understanding between them and the health agencies. Hence, health spending is better prioritized and institutional funding bottlenecks are removed. Promoting the awareness and sensitization of policymakers, including the legislators, on health initiatives and reforms through simplified content that is tailored for a non-technical audience can boost the government's responsiveness, promote ownership, and increase resources allocated for health. Successful operationalization of policy and financing reforms and efforts to influence behaviors take time to build trust, relationships, and capacity. Government engagement to implement policy actions can be time-consuming due to bureaucratic processes and frequent staff turnover. By fostering effective, continuous communication between stakeholders involved in the administration and implementation of health policies, implementing partners can promote trust among all actors and across all tiers of government and community to promote accountable stewardship of health policy. The states have shown that strengthening primary health care by implementing reforms such as primary health care under one roof and the basic healthcare provision fund, spending health insurance, and improving domestic resources for health helps to improve access to quality healthcare, financial protection, and health outcomes. This is clear positive implications for Nigeria's journey to self-reliance and progress towards universal healthcare. So over to you, Francis.
Francis, you'll want to unmute, please.
Thank you very much, Senator. Sorry about that. So, yes, so we appreciate everyone for taking out your time to listen, for us share this approach that we have used, which is a highly unique, replicable approach or model in strengthening the Nigerian healthcare system and in providing support to the Nigerian healthcare system in their journey towards universal health coverage. And we hope that other countries and other partners who want to implement similar health system strengthening efforts would find these things and find our approach a useful model to replicate. We would like to give a special thanks to the USAID, who actually made all of this possible. In addition to the government of Nigeria at the federal level, the federal ministries of health and the agencies, the state ministries of health in Osun, Abia, Ebonyi, and FCT, and the state governments, the primary healthcare agencies, the state health insurance schemes, the local government health authorities, the primary healthcare facilities, the ward development committees, and the civil society organizations that supported the work that we do. But of course, we also want to thank the communities who actually rallied around these interventions when they saw the benefits that it could have to their communities. Special thanks to Ramota, whose story has been changed, whose life has been changed and whose story has actually been shared and is always very, very emotional to a lot of people. So we want to thank all these people without which this work that we did wouldn't have been possible. So at this time, I would like to invite my colleague, Bethany, to lead the question and answer session.
Thank you so much, Francis, and just thank you so much to our panel. This has been such an interesting presentation, and I'm really excited to start engaging with the audience now and hear from your questions. So what I'll do for our panel, just because I'm conscious of time, is I will read the first two questions aloud, and then any panelist can just jump in. So the first question I have is from Siddharth, As I understand, the BHCPF will only be implemented in rural areas for the first 5 years. What about the urban poor and vulnerable population, given that more than 50% of Nigeria is now urbanized? Is there any plan for them? So that's our first question. And the second is from Manji. Please, in terms of domestic resource mobilization, is there anything that has been done at the community level, maybe with structures like the ward development committees? We would like to know more about this if anything has been done. So panel, over to you.
Thank you very much. I would like to take the questions, and then I'll give other panelists the opportunity to answer. So with regards to the Basic Healthcare Provision Fund, so the initial design of the Basic Healthcare Provision Fund, there was a targeting of rural communities. But I think that over the course of the design of the implementation package, that was not sustained. So the Basic Healthcare Provision Fund is actually going as additional funds, as well as meant to catalyze spending at the state level. So if you recall from what Dr. Ogini said, so the state government is putting down some funds. The people who can contribute are also contributing funds. Now the Basic Healthcare Provision Fund aspect of the money would actually go to cover the poor and vulnerable across board, both rural and urban settings. So that actually takes care of the fears that you had around what about the urban poor. So everybody is actually covered. So the plan is to cover people who can contribute will contribute through the health insurance schemes. People who cannot contribute, the money from the Basic Healthcare Provision Fund would actually complement the efforts that the state governments are already making to be able to cover a wider population.
That's true.
With regards to domestic resource mobilization through WDCs, so I had shared some examples of how WDCs are mobilizing philanthropists in the communities to actually be more responsive to the needs of the community. So the domestic resource mobilization, you actually write, the efforts are across board. So apart from the efforts from the state government in releasing more funding, at the local government level, there are also efforts to get the local governments to actually allocate and release more funds to the facilities, as well as the community efforts. In many of the communities rallied around to get philanthropies and contribute money among themselves to buy hospital beds, to buy basic hospital equipment, to renovate facilities, build up walls, repair leaking roofs, provide electricity and water supply to these facilities. So I actually agree with you that that is one very big area of domestic resource mobilization, which actually moving forward should be quantified.
Yeah, thank you, Francis. In addition to that, individuals in the community use the adoption model under our state health insurance scheme to provide funds to pay for the premium of identified vulnerable persons in their communities. So talking about the urban poor, aside from the Basic Healthcare Provision Fund, under the state health insurance scheme, we have identified individuals within communities who adopt 10, who adopt 15 or 20. The recent one we had was actually 30, that one individual paid the premium for 30 indigent people in the community to access care for 1 year under the scheme. So this is another source of mobilizing funds from the communities to take care of the rural, urban, and the urban poor people. Thank you.
Great. Okay, we will move to our next batch of questions. The next one is from Bev Johnston. Thank you for your presentation and congratulations on your significant successes. What lessons learned do you have to share around engaging civil society through social accountability approaches? That's the first question, and I'll read the second one. How was revenue raised from the informal sector and the poor in a sustainable way besides the governance funding? Over to you, panel.
Sorry, Bethany, could you repeat the second question, please?
Of course. How was revenue raised from the informal sector and the poor in a sustainable way besides the governance funding?
Right.
Well,
Okay, thank you very much. Dr. Ogini,
okay.
you can go first, yeah?
Yes, what I actually, you said, how was revenue raised from the informal sector aside from the government funds? This we did working together with civil societies organizations. In our own scheme, we engage them as third-party administrators, and we give them an incentive. As a third-party administrator, you work with the informal sector, the artisans, the traders. If you get them to pay the premium, the civil society organization gets 1.5% of the premium that is paid to the agency. So there's accelerated activities in the informal sector to get people to buy into the scheme. And when they get encounter with our services, they become people who market the scheme to tell other people in the informal sector to come and register. So we are seeing accelerated enrollment as a result of this work we have done together with the civil societies organizations that served as our third-party administrators. Thank you.
Thank you very much, Dr. Ogini. So I'll take the first question. So with regards to how civil societies were engaged for social accountability. So we actually had a model where we engaged the civil society organizations at the local level. And we did a mapping of the ones that were the most active and the most influential. And those were the people that we worked with. So first of all, we engaged them. We had interactions with them. We had meetings with them where we identified mutual commonalities and goals and benefits. And they were actually very happy to work on the basic healthcare provision fund. So we conducted a training for them to build their capacity to understand the basic healthcare provision fund. After that, they were actually the ones that went into the communities to do the town hall meetings with the support of the ward development committees, who brought the community members together, males, females, across all key population groups. And the civil society organizations, as a result of their experience in this aspect, was able to speak to the communities in the language they would understand, using things they could relate with and that was actually what led to the response that we got from the communities in enrollment, in trying to be part of these interventions. In addition to that, we also linked the CSOs to the government agencies that were responsible for implementing this reform. So they had easy access to these government agencies to provide feedback to them on a regular basis on what the communities are saying about, is this working, what could work better, and things around that. And it was actually good news to us to hear 1 month after the project ended that many of the CSOs have actually gone ahead to include some of these things in their own work plan of their own CSO activities. And for us, that is what self-reliance is all about.
Thank you so much, Francis and Dr. Ogini, and to our entire panel. We have reached the end of the webinar. I'm so sorry we didn't have enough time to answer everyone's questions. But again, I just wanted to thank all of the panelists for sharing your work with us. And to all of our attendees, thank you so much for taking an hour out of your day to engage with us on the wonderful work that we've done in Nigeria. And everybody is going to receive an automatically generated email in the next few days with the link to visit our HP Plus Webinars website. And that's where you can access the recording from this broadcast, as well as check out past and future webinars that we'll be holding. We have 3 on the books for July. So we hope to see you back here in a few short weeks. And just thanks again, everyone. Take good care, and we'll see you next time.
Thank you.
Thank you.
Thank you.